Okay, good afternoon. We're going to get started if everyone can get situated. My name's Tenko. I'm here with Christopher Wolfgang. We're happy to be moderating the next session, which is Emerging Therapy and Surgery of PDAC. We have some outstanding speakers, so we're really looking forward to an excellent session. Our first speaker is Dr. Tim Donahue from David Giffen School of Medicine at UCLA. He's the Chief of Division of Surgical Oncology and Professor of Surgery. And he also has a joint appointment in the Department of Molecular and Medical Pharmacology. He has an active research program in pancreatic cancer. And he's also the surgical director of the UCLA Aggie Hirschberg Center of Pancreatic Diseases. Dr. Donahue?
Great, thanks so much. Thanks so much for asking me to speak today. Just one disclosure, I'm on the board of directors of a company we've spun out of our laboratory. I was asked to talk about surgical management of pancreatic cancer, but I noticed that Marcus Buchler was talking after me, and certainly would be able to show a lot better pictures of, divestment dissections and whatnot. So I've pivoted a little bit to talking about management of early stage pancreatic cancer. Last year I talked about the RIGHT, the locally advanced disease and changes in treatment and approaches to locally advanced disease. But this year I'm going to talk about the earlier stage disease, resectable disease, and borderline resectable disease. And what I really want to get at is what's the current status and the direction of the field. Recent lessons that we've learned from patients who have been treated preoperatively. And that, given that we're trending towards what appears to be longer course neoadjuvant chemo or total neoadjuvant chemo, do all patients need adjuvant chemotherapy, I think is potentially a question coming down the pipe. Look at some literature from this year from the surgical literature on tissue prognostic biomarkers in patients who have been treated preoperatively to start to get at that question. So if we look at the current NCCN, or where are we currently patients with resectable disease, the NCCN guidelines, you can see for those with resectable disease, there's a box there that says consider neoadjuvant therapy. And this is in patients who have signs or symptoms that they might be high risk for having more advanced disease than what is thought to be potentially resectable. But NCCN allows for neoadjuvant therapy or consideration of neoadjuvant therapy. Look at borderline resectable disease. Here's the NCCN block where they do recommend, or I guess I should say we recommend, a neoadjuvant therapy, but put a little caveat there that there's limited evidence for the regimen or the duration of therapy that's optimal for these patients. Fortunately, there are a number of recent or ongoing clinical trials, collaborative group clinical trials in this space, which I think are going to begin to answer some of these questions. But I also want to just draw your attention to most of these trials also include adjuvant therapy as part of the schema for the treatment of these patients. I want to highlight just a few of these studies. First is the Swog 1505 study, which I think was a really informative study where patients with resectable disease were randomized to getting perioperative FOLFIRINOX or gemcitabine and Abraxane. The survival from this study was lower than what was expected considering the Prognostic study, but I think the deliverables from this study are that it really set the stage for us to be able to do neoadjuvant or perioperative clinical trials for patients with pancreatic cancer. And fortunately, 90% of patients completed their chemotherapy regimen. Really like this study, which came out of the MGH group, where they gave total neoadjuvant therapy for borderline resectable and locally advanced patients. They got FOLFIRINOX and losartan and chemoradiotherapy before surgery. But you can see here the median survival achieved, this is borderline resectable locally advanced, I think was outstanding at 33 months. And take-home message for me from this at least was that total neoadjuvant chemotherapy can achieve an excellent survival. I think many know about the current Alliance trial that's now accruing patients. led by Christina Ferroni, where resectable patients are being randomized to perioperative FOLFIRINOX or preoperative FOLFIRINOX versus total adjuvant FOLFIRINOX. And I really like the design of this study in that the 12 cycles in the perioperative group or the preoperative group, 8 of them are given before surgery, with just the remaining 4 given after surgery. So, as I said, also like to talk about what, for patients who are treated preoperatively, are we going to get to the point, or are we getting to the point that do all patients also need adjuvant chemotherapy, especially with more and more treatment given before surgery? And if we kind of map this back to the Alliance study, the question I'm asking is do all patients need this additional treatment after surgery? Again, back to the NCCN to give what the current status of things are. If you look at potentially resectable, borderline resectable, and locally advanced, the NCCN says that in patients who have gotten pre-op therapy after surgery, you can consider additional chemotherapy or chemoradiotherapy for patients with positive margins. But no strong evidence there, again, to give treatment even after surgery. I think we can start to answer this question if we look at some of the literature from this past year from the surgical literature, patients who received pre-op chemo who had surgery, and some of the tissue biomarkers that were analyzed. We joined forces to look at resection margin with the Hopkins group and Mayo Clinic. This has been one that's been hotly debated, whether or not resection margin is important, especially or in patients who have received preoperative therapy. And we found that it was significant, and that the patients who had an R0 resection margin had a longer median survival than patients who had a microscopic positive resection margin. This isn't as consistent in a number of other studies that were done, including by the Heidelberg group, Marcus's group, that looked at substratified R1 resection into less than a millimeter versus direct. While it was significant in the univariate analysis, it kind of fell out in the multivariate analysis of their study. The Hopkins group also did this independently and found in their series that resection margin also was insignificant, similar to the Heidelberg data. But what was significant was the histopathologic response to treatment. And so we wanted to look at this too. We joined forces with Hopkins again and Mass General and looked at 525 patients. Some had received chemo only, some had received chemo radiotherapy, and used the CAP score, the College of American Pathologists score, 4-point system, where 0 is essentially no tumor cells left, and 3 is a poor response or no response. And I think that there's some interesting findings here. The patients who had chemoradiotherapy had significantly better CAP scores or histopathologic responses than the chemotherapy group. And the point of this study was not to compare chemo versus chemoradiotherapy, as this is a retrospective study, and patient-by-patient decisions are made at tumor boards. But what we did find is that for both groups, that histopathologic response was predictive of survival, and that, interestingly, in the chemo group, a grade 2 response was better than grade 3. You can see the green line versus the blue line. But those patients who got chemoradiotherapy, the grade 2 was not any better than grade 3. Mark Trudy's group also looked at a number of factors. So these are tissue prognostic factors, or tissue factors related to survival in patients who had received neoadjuvant therapy, and they found that more duration at chemo or CA19-9 and major histopathologic response all were associated with better survival in patients who had received pre-op chemo. and combined them to this combined score where, I thought it was pretty prognostic or predictive of survival in patients who had been treated before surgery. And so there have been a couple studies that were done this last year that more directly answer that question: do all patients need adjuvant chemotherapy? One is, I guess, from a little while ago, from the Medical College of Wisconsin. They asked, they took 121 potentially resectable, 113 borderline resectable patients. This is a retrospective study who had received neoadjuvant chemotherapy, and they found that only the patients who had node-positive disease benefited from additional therapy after surgery. So just the node-positive subgroup of patients derived any benefit from additional chemo. Mark Besselink's group also looked at this. So their collaborative group, the European African Hepatopancreaticobiliary Association, published a paper this last year in JAMA Oncology, where they looked at 520 patients, all got neoadjuvant therapy with FOLFIRINOX. The median duration of treatment was 6 cycles, and they compared the groups who got adjuvant therapy versus the group that didn't get adjuvant therapy. And if you first look at all patients that were in this study, so retrospective study, there was no difference in median survival comparing those who got adjuvant versus those who did not get adjuvant treatment. And the median overall survival was 29 months. This also held for the node-negative patients, so 256 node-negative patients. No difference in survival between those who got adjuvant versus those who did not. But the node-positive patients, you can see they derive benefit from additional adjuvant therapy after surgery. Median survival of 26 months versus 13 months in those who did not get any adjuvant treatment. And this remains significant on multivariate analysis. So they found that there was even a doubling in survival of the node-positive patients. Some other interesting, important information from this study were the insignificant predictors. The number of neoadjuvant FOLFIRINOX cycles didn't seem to interact with adjuvant therapy. The margin status, tumor grade, T-stage also didn't predict or was not associated with who benefited from adjuvant therapy. They didn't include in this study that histopathologic response, or the CAP score, that I had talked about in those other studies, or any serum biomarkers like CA19-9. So in conclusion here, for the management of early stage pancreatic cancer, I think that this Alliance study, it's a well-designed trial for resectable disease. I like that they're giving, or most of the treatment is being given up front before surgery and just 4 cycles afterwards. But I think we can derive even more information from this study about our next steps and trying to think of the next questions about where we're going. The prognostic factors, tissue factors, histopathologic response, or lymph node status, other serum candidates that have been thrown around in the literature, CA19-9, CTCs, KRAS, circulating tumor DNA, and I predict that the next steps might be incorporating these into who would also benefit from adjuvant therapy after surgery, in addition to having treatment before their operation. So thanks again for the opportunity to talk. I'd be happy to take any questions.
Thank you.
Actually, if you don't mind, while we're waiting for folks to come up, so thanks for that excellent talk, as always, nicely presented. Actually, a couple of questions. So obviously talking about the question whether or not, to do adjuvant in patients who've had maybe less than 6 months of treatment up front, or in fact, even if only 4 months do they need. Actually, backing up one step, I'd be curious that it sounds like at your institution, essentially everybody gets neoadjuvant. For the most part. And I'm just wondering your thoughts on your experience with over the years with the volume. Is it, Do you adjust the timing of the adjuvant or the need for adjuvant based on what is probably our best liquid biomarker at this point, which is CA19-9? Obviously, there's others. So in other words, if you have somebody who comes in with an essentially normal CA19-9, they are a CA19-9 expressor, do you ever consider doing surgery first? At the other extreme, have you ever, patients who say CA19-9's 1200 range, they start on therapy, never progress, are you willing to say they should never go to surgery, or do you treat until you get the desirable drop, I guess is what I'm trying to say.
Good question. I mean, full disclosure, we don't give neoadjuvant therapy for the potentially resectable patients. I think that there was a recent poll done at GI ASCO where I think the room was split 50-50. But if you look at ASCO guidelines, they suggest that patients who have CA19-9 over 1,000 are essentially biochemically borderline resectable or locally advanced, and even an indication to give neoadjuvant therapy but before surgery. I mean, there's some weak evidence, but that's what the ASCO guidelines suggest. I think the scenario I'm more thinking about or talking about is in patients who have borderline resectable disease. Say we're able to get the full course of chemo into them before surgery, 6 months or so, take them to surgery, and tumors removed, and they have node-positive disease. It's our oncologist's approach and practice to not give them any additional adjuvant therapy because they've received a full 6-month course of chemo, which I think is somewhat, or 12 cycles, is somewhat of an arbitrary number and one that's just used in studies. Right. But the data is really showing, as I said, that more and more treatments being moved up front before surgery. And there appears to be a subgroup of patients that may not benefit from more therapy after surgery. There may be some who do benefit from it. But I think we can probably get to find that answer a little bit in that prospective alliance study. We're going to be able to generate some rigorous data.
I agree. Any other questions? Okay. Thank you very much.
Chris.
Excellent talk.
Yep.
So, Professor Buchler, can you hear me? I think Professor Buchler is going to be...
Yes, I can hear you.
Professor,
hello.
Welcome. Welcome. This is Chris Wolfgang here. Professor Buchler,
Hi, Chris.
how you doing? So it's my pleasure to introduce Professor Bushler, who we know is the chairman of the Department of Surgery in Heidelberg, and really probably one of the most prominent pancreatic surgeons in the world. Has really led the field and is considered a thought leader in pancreatic surgery, not only on the technical aspects, but also has done a lot of work in leading both translational research and clinical trials, is really one of the sort of the driving forces of the SPAC series of clinical trials. And has numerous publications ranging from technical aspects to surgery to biological aspects, well over 500 publications. So really a thought leader. As you probably know, he started at Ulm when he began his faculty career, quickly rose to the chair of surgery at Ulm, and then was recruited to Switzerland at Bern, spent some time at Switzerland, and then came back to what was already a very prominent program in Heidelberg as the chair. But since I believe it was around 2001, has built that program probably into what is the busiest pancreatic surgery program in the world. And so I'm really excited to hear what he has to say about surgical therapy for PDAC. I know it's about 6 hours ahead. I hope, like last time I saw you present, you're sitting in your home study with a glass of wine, because I know it's late over there, and we look forward to your presentation.
Good morning, ladies and gentlemen. It's my great pleasure to lecture for you in Miami. It's Thursday morning. I'm in the OR in Heidelberg. Dear Dr. Ko, dear Dr. Chris Wolfgang, I will lecture about surgical therapy of pancreatic cancer. You have given me only 12 minutes. I will do my very best to stay in time, or I will stop after 12 minutes. Now, pancreatic cancer. I tell you some facts and some news. Fact, ladies and gentlemen, in 2021 is that in resectable pancreatic cancer, the standard of care is surgery plus adjuvant therapy. Certainly in locally advanced or primarily unresectable pancreatic cancer, neoadjuvant treatment is the choice, but in resectable pancreatic cancer, the standard of today is surgery plus adjuvant. Why I can say this? Look at these data that you know very well, published in the New England Journal from the Canadian-French multicenter trial, the Prognostic trial, where they used adjuvant FOLFIRINOX. The median overall survival was 55 months, as you can see here. And these data have never been reached by other groups or by other treatment modalities, particularly not by neoadjuvant treatment. So this is the reason why this is the standard of care. Certainly, surgery is the only measure that together with chemotherapy will achieve this result. So radical surgery plus adjuvant or neoadjuvant will achieve the results I have shown to you. However, what is radical surgery? You see here the so-called triangle. This is the superior mesenteric artery, celiac trunk, hepatic artery, portal vein with end-to-end resection. This is the triangle, ladies and gentlemen. Within the triangle, local recurrence happens. Unfortunately, most of the surgeons around the world do not clean the triangle, and part of this is then the reason why patients develop local recurrence. Overall, 30 to 50% of pancreatic cancer patients after surgery develop local recurrence, and therefore it is very important to think about why they develop local recurrence. Most of local recurrence is so-called local recurrence. Most of local recurrence is persistent cancer after surgery because the field has not been cleaned. Now, this is from Mayo Clinic, recently published by Dr. Mark Truty. This is very advanced pancreatic cancer surgery. You see here this Y prosthesis on the aorta and then one arm to the hepatic artery and one arm to the supramesenteric artery. So if you keep this in mind, this is very radical. Very once in a while we do this as well, and you see here a patch on the portal vein to get the field clean. So this is the article of Mark Truty from Mayo Clinic about 111 patients where he did arterial resection. Now, what is the problem, ladies and gentlemen? Here you see a non-radical resection, patient after a Whipple, 3 months post-op. Your radiologist will tell you, there's something, I'm not sure. There's tissue around the artery. This is after 6 months and this is after 9 months. Now everybody sees the persistent cancer grows in the field that has to be cleaned to achieve an R0 resection, but a real R0, 1 millimeter distance to the tumor. And then together with adjuvant chemotherapy, you reach the good survival figures. We have developed the triangle operation. I cannot go into detail, but please read the data about the triangle operation. This is for such kind of patients here. This is after neoadjuvant treatment, 12 cycles of FOLFIRINOX. Your radiologist will tell you this is unresectable, tumor still there, no change. But you know, and you have to know that after neoadjuvant treatment, very frequently there's just the bulk of tissue there, but there is not much or no more pancreatic cancer in such bulk of fibrous tissue, as you can see here. This is the same patient after surgery, celiac trunk, hepatic artery, supramesenteric artery, portal vein with end-to-end and vena cava here. And this is the triangle that has been cleaned after neoadjuvant treatment and surgery. Show another example of the triangle. You see here the portal vein, supramesenteric vein, portal vein, supramesenteric artery, celiac trunk. This is the triangle, and the triangle is cleaned. I just give you one information. Our patients, quite frequently, 20 to 40% have diarrhea after surgery. You would say, diarrhea, this is a bad side effect. I have to tell you something. If your patients never have diarrhea after a Whipple, you should think about your technique to clean the field. We recently published the first 200 patients where we applied the triangle operation, and the result was that with the triangle operation we get more R0 and more lymph nodes, so it seems to make sense. Now in Heidelberg we do a lot of pancreatic surgery, as you know, 12,000 of such operations since I'm responsible here. We do 3 to 5 Whipples per day, and whoever is interested, you are all invited to come and see what we do. Most of what we do is for pancreatic cancer, 80%. Most of what we do are Whipples, 5,300, and we also do many left resections and total pancreatectomy. As you know, some patients need total pancreatectomy for a radical resection. Our overall figures of reoperation, 9%, fistula B and C, 8%, and overall 90-day perioperative mortality, 2.9%. Now this is another just example. You see the liver after neoadjuvant treatment, the blue liver, and then you see the end-to-end supramesenteric artery, you see the end-to-end portal vein, and you see the end-to-end here hepatic artery replacement and reconstruction. This is what we do regularly meanwhile to get a clean field and a real R0. R0, this is our published data about the new R0 status, 1 millimeter distance to the tumor, 560 patients, recently published. And as you can see, if you achieve a real R0, 1 millimeter distance to the tumor, then the results are 40-40, 40 months median survival and 40% 5-year survival. All of this is in combination with adjuvant treatment, and I think 40-40 is just a good result for radical surgery plus adjuvant chemotherapy. Same is true if you do pancreatic left resections, as you can see here, also a 1 millimeter distance to the tumor, 450 patients, and as you can see, if we achieve a real R0 in the pancreatic left resections, then you can see that we have a 60-50, 60 months median survival and 50% 5-year survival. So it pays out, ladies and gentlemen, to do a radical pancreatic resection to clean the field, a triangle operation, together with adjuvant chemotherapy. You reach quite considerably better results than former times. We have developed many new techniques for radical pancreatic surgery. I cannot go into detail. All of these are published, ladies and gentlemen. You can read them. Artery first. So we do not go to the pancreas and cut the pancreas above the portal vein. We first go to the arteries behind the pancreas. This is the left renal vein, inferior vena cava, aorta, and here you see the offspring of the supramesenteric artery that we disclose before we go to do any kind of surgery at the pancreas. We also do the so-called uncinate process. So we start at the uncinate process and we travel upwards the artery and the vein, and only at the end we cut the pancreas. We do a lot of vascular replacement, as you can see here, a prosthesis of the portal vein, as well as a prosthesis of the celiac trunk. Now we also use the splenic artery for reconstruction, ladies and gentlemen. I cannot go into more detail, but I think it will pay out if you come and visit us to see what we do. I'm moving a little bit forward. Arterial resection is an issue. We recently published about 400 patients. We also do so-called arterial divestment, where we go close to the artery or even into the arterial wall and clean the field. As you can see here, the bulk around the supramesenteric artery. After neoadjuvant treatment, we then do the divestment along the supramesenteric artery. This is the specimen after divestment. Locally advanced, I cannot go into detail. I finish up, ladies and gentlemen. The standard of care today is radical surgery plus adjuvant treatment. We have been putting down the principles of adjuvant treatment. This is our first article of the ESPAC trial number 1. You remember very well, we could show that adjuvant treatment is better than surgery. Meanwhile, this is a standard of care. We recently published our ESPAC 4 trial that showed the same. So I finish after 12 minutes and 30 seconds, ladies and gentlemen. Pancreatic cancer surgery has considerably changed. What we have to do is to clean the field in a real R0 resection and combine this either with adjuvant treatment or neoadjuvant treatment. This will achieve much better survival figures than in the past, and surgery is the milestone of these achievements. Thanks for your attention.
Professor Buchler, excellent presentation and excellent job on the timing. As we'll wait for some folks to gather here, maybe I'll get started. You know, you and I had discussed this and both had published on the arterial divestment technique, and I know that there's a lot of sort of criticism and actually sort of pro-divestment and a lot of discussion going on regarding that, and I think people look at it as an either-or with SMA resection and reconstruction, but it's not a real either-or. And I was just wondering if you give your thoughts on when to divest and when to resect SMA.
Yeah, Chris, thanks for this question. Thank you again giving me the honor to present here. Unfortunately, we cannot travel well to the US, and I hope we will be able to come very soon again so that we can discuss. Now, the question of divestment, if there was neoadjuvant treatment, which I think is extremely important, only then we can do a right and fine-tuned divestment. If this is a primary surgery, then normally you don't get the cancer of the artery. But after neoadjuvant and shrinking of the tumor, there's this bulk left, and we are quite regularly able to divest. We send it to frozen section, and depending on the amount of infiltration, we do a resection of the artery or not. So in a way, it is an either or, but it is also not an either or because we do the resection by purpose if there is no neoadjuvant. But if there was neoadjuvant, we start with a divestment and then potentially do a resection of the artery.
Yeah, great. So just to summarize and clarify, you would intraoperatively convert somebody from an R1 to an R0 by resecting and reconstructing SMA with a positive frozen.
For example, or the celiac trunk or the hepatic artery, or what is necessary.
Yeah. So I think Dr. Tempero's coming up for a question.
Hi, Marcus. Thank
Hello,
you
Margaret.
thank you for your wonderful presentation. I just want to kind of reflect on the FOLFIRINOX data that you presented. Those patients are athletes, you know. They were able to be resected. They were able to recover from surgery, and they were able to take FOLFIRINOX. So they're not the real universe. So if you could, like, weigh in on what it would be like if you included all those other patients in the data set.
Yeah. Thank you, Margaret. You touch the field very well because you know. We have this controversy of neoadjuvant to adjuvant. The data for neoadjuvant are very, very weak when it comes to resectable. The data for adjuvant are very strong when it comes to resectable. So I understand your question that some of the patients will never reach adjuvant treatment because they have surgical complications, they are weak, they are malnourished. I understand this concern very well. I think I cannot say that adjuvant is the 100% solution, but what I must say is so far, the evidence for adjuvant is very strong, and the evidence for neoadjuvant in resectable is very weak. So what should we do? We need more trials.
Professor Lurch.
Hello, Marcus. This is Marcus Lurch.
Hello.
Good to see you. You've been operating the world over, and what I don't understand as a non-surgeon is the triangle approach. Is it more radical or is it just more thorough? And my second question is, what are the differences between countries in terms of surgeons being radical or non-radical or conservative, or rather being R1 than having any complications?
So I need 2 years to answer all these concerns, my friend. Let me try in 1 minute. So number one, radical surgeons in the different continents, it's so difficult. I have to give honor to the Japanese. They were the ones that started with radical surgery. Unfortunately, in the 1980s and 90s, there was no standardized adjuvant or neoadjuvant treatment, and therefore the surgical approach alone was not enough. So this was kind of a failure. Meanwhile, we know about the advantage of neoadjuvant or adjuvant chemotherapy. So this, together with radical surgery, is probably what we can offer at this moment in 2021. And therefore, surgery has to become more radical. Yes, I'm in favor for that. To clean the field before the circulating cancer cells will be killed by adjuvant chemotherapy. And this is the options at the moment. I'm sure that in the future there will be more options. And then the triangle, the problem is that when I speak to my gastroenterologists, they say, listen, a surgical procedure with 50% local recurrence, this is a very bad surgery. This is what they tell me. I say, no, wait a moment. Pancreatic cancer is different from, no, it's not different. If you have 50% local recurrence, something is wrong with your surgery. And this is where we work to improve this local recurrence rate by cleaning the field, by going more deep in the back where local recurrence happens. So let's see whether the outcomes will be constantly better in the future. Now, continental differences, yes. America is still very, very conservative as against your government, which seems to be more progressive now. But the surgery is still very conservative. So should we change this? I don't know. Surgeons like Chris Wolfgang and Mark Truti and some others have started to be more radical. Let's see. Surgeons in Japan are the most experienced in radical surgery, and we in Europe, we try to be more radical. That's the definitions.
Thank you very much, Mark.
Just real quickly to follow up, I know time is running low, but I would say that clearing that Heidelberg triangle or the triangle operation, which I do routinely, I wouldn't call that radical. I think I would, and Marcus would agree with me that that's just part of an adequate operation, even in someone who doesn't have a large bulky tumor. If you look at localized recurrences, that's the region of soft tissue where you get those localized recurrences. And so I wouldn't call that really radical. That just should be, I think, part of the standard.
I agree with you, Chris, but you know that when I ask my friends whether they see the offspring of the supramesenteric artery in the celiac trunk regularly, they say, no, I don't see this triangle. And this is the reason why we speak about. But I know that you are doing this regularly, as we do. And remember this little story with the diarrhea.
Yeah.
If you have diarrhea in your patients, you have done the right operation.
I'm in a good place then.
All right, thank you, Professor.
Thank you.
Yeah, our next speaker is Dr. Sabita Roy, who is a professor of surgery at the University of Miami Health System. Dr. Roy's laboratory has been working on opioids. Specifically, the goals of her study is to identify therapeutic targets that can prolong opioid use and minimize its comorbidity. So Dr. Roy is going to talk to us about pain management in pancreatic cancer. Dr. Roy?
First and foremost, I'd like to thank Dr. Saluja for introducing us to pancreatology and trying to convince us that the pancreas is the only organ worth studying. Anyway, my talk today is the role of the gut microbiome in pain sensitization. So 70%, or we've been hearing all through the morning and yesterday that 75% of cancer patients, particularly patients with metastatic cancer, suffer from pain with a mean intensity of about 6.4. Pain intensity that's strong has a strong and deep and piercing pain. It dominates your senses and causing you to think unclearly and trouble holding a job or maintaining a normal and a social relationship. So controlling pain is an essential part of cancer treatment. A recent NIDDK workshop has sponsored by the National Institute of identified research gaps and opportunities in pancreatic pain. And one of the identified gaps was the need to better understand the underlying mechanism of pain in pancreatic diseases. So WHO has a three-step ladder for pain management, and to make a start, so restore opioids as the standard for pain management for moderate to severe pain, and which is recommended by WHO. But one of the major limitations for long-term opioid use in cancer patients is the development of analgesic tolerance, where larger and larger doses are required for the same or even less pain relief. Thus, escalating opioid doses are needed to achieve the same level of pain, and this contributes to dependence and addiction, thus limiting the use of long-term opioids for pain management. We have previously shown that opioid use in animals, in preclinical studies, results in significant disruption in the gut morphology, leading to gut barrier disruption, causing localization or dislocalization of tight junction proteins, leading to a significant increase in bacterial translocation systemically. We also show that this is probably due to gut dysbiosis or change in the gut microbiome. And you can see on the left-hand side a PCAO plot that shows that the morphine-treated group was significantly different. The microbial community in the morphine group was significantly different from the control group. Similarly, we see differences in metabolome from the same microbial material. And then when we looked at the host transcriptome, we see significant changes in up and down regulation of transcription factors in the host. So there is a multi-omics disorganization in the presence of opioid use in an animal model system. So the question we asked then is, does the disruption of the gut microbiome contribute to opioid analgesic tolerance? And this work has been done by a very talented graduate student. We used two analgesic methods to measure pain. One is the tail flick method, and the other is a hot plate method. I will not go into detail because of my 12-minute limitation. But so one of the ways we tried to look at if the gut microbiota is important in opiate tolerance was to use germ-free mice. Germ-free mice are mice that has not previously been exposed to any bugs. And so these mice, so to study anything that is associated with microbiome, this would be a great model to use. So what we use is continuous opiate treatment model where we give these mice escalating doses of opioids for 7 days. And this is, we have shown previously that this results in tolerance. And usually, when you then challenge these mice with a test dose of opioid to test if opioids are still producing analgesic effect, we find that these animals are totally tolerant and that test dose of opioid no longer induces any analgesia in the morphine-treated animals. However, the control animals or the saline-treated animals show maximal effect with that same dose. So when similar treatment was done in the germ-free mice, we show that the repeated doses of opioids in the germ-free mice no longer was able to induce tolerance in this animal, implicating that the gut microbiota may be associated with opioid tolerance. However, to further prove that this biome is responsible, we gavaged these mice with a fecal microbial transplant from wild-type mice, where these mice were engrafted with fecal microbiome, the germ-free mice. So now this acquires the microbiome of the wild-type mice. And then these animals were treated with escalating doses of morphine and challenged with a test dose of morphine. And here again, you see that although the germ-free mice without the microbiome was unable to, or had an attenuated morphine tolerance, when microbiome was reinstated in these animals, we see significant opioid tolerance in these animals, suggesting that the gut microbiome was directly a causal effect in the modulation of the gut of opioid tolerance. We further validated this using antibiotic treatment, where animals were treated with a cocktail of antibiotics and then treated with an escalating doses of morphine and then tested with a test dose of analgesic opioid. Here again, in the wild-type animals, we see significant tolerance development. However, in the animals that were treated with antibiotics, morphine tolerance was attenuated, again implicating that the gut microbiome was responsible for driving morphine-induced tolerance. When we further looked at gut permeability, as well as we see that gut permeability was also significantly attenuated in animals that received antibiotic treatment. One other essential experiment that we did was to transfer either placebo or microbiome from the control animal or the microbiome from morphine animals into just naive antibiotic-treated animals. And we show that the morphine microbiome was sufficient to induce gut permeability and increase bacterial translocation, implicating that the dysbiotic microbiome was primarily responsible for some of the comorbidities that you see with chronic opioid treatment. So what is the role of the gut microbiome in cancer? Several studies have shown that it induces cancer progression, metastasis. It modulates cancer immune therapy, induces chemoresistance. And here we are trying to establish that the gut microbiome also has a significant effect on cancer pain. So pancreatic cancer pain can be visceral, somatic, or neuropathic. Somatic and neuropathic pain may arise from tumor extension into the surrounding peritoneum, retroperitoneum and bones, and visceral nociceptive signals are caused by damage to the upper abdominal viscera, tension, and stretch. So how is pain perceived? The pain is perceived by pain receptors, and this can be thermal, mechanical, or chemical. The thermal pain receptors are the TRPV1 receptors. Mechanical pain receptors are perceived by the purinergic receptors or the TRK receptors, and chemical pains are recognized by acid-sensing ion channel. However, these receptors are not activated by these insults immediately. They need to be sensitized, and the sensitizing agent most of the time is inflammation. So only under inflammatory condition are these pain receptors activated and sensitized and perceive this external stimuli or the nociceptive stimuli as painful. So where does this inflammation come from to sensitize or sensitize these pain receptors? And one of the postulated mechanism is that the gut microbiome or a dysbiotic microbiome can result in the sensitization of pain. So if you have an expansion of pathogenic bugs, this then induces gut barrier disruption, translocation, and activate toll-like receptors on the lamina propria of the epithelial cells, as well as immune cells in the mucosal immune area. Once again, bacterial products can also modulate sensory neurons as well as the enteric nervous system, where toll-like receptors have been found on glial cells as well as astrocytes. This then results in the sensitization of the dorsal root ganglion and thereby activating the TRPV tract receptors, and therefore when stimulus for activating these receptors are released because of cancer or any other painful stimuli, this then is perceived as pain, at least at the spinal level and also at the supraspinal level. At the same time, there are bacterial communities that can be analgesic, and this can actually inhibit this pain receptor sensitization and thereby can induce analgesia. And this has been one of target for pain therapy also in several, as an adjunct to pain therapy. So what is the role of microbiome in cancer pain? Then we, to understand or to at least use a model system where we can test the mechanism by which cancer pain occurs, Dr. Ramakrishnan's group helped us with this orthotopic pancreatic cancer model with Dr. Bhuvan Giri, where orthotopically KPC cells were injected in a matricial system into the pancreas, and then the pain was evaluated at day 14 and at day 21. Antibiotics were also given in another set of animals. These were done before the introduction of the cells, and antibiotics was sustained in the drinking water. I'll go fast. And then pain was measured, either a mechanical pain was measured using Von Frey, and again, thermal pain was using tail flick, as I described earlier. So microbiome depletion, as you can see clearly that there was a significant decrease in the primary tumor size as well as the metastatic tumor, and the total tumor burden was significantly decreased in the presence of antibiotics. When we looked at pain measurement, and we saw that there was a significant sensitization of pain, so by both the von Frey method and the tail flick method, implicating that as the cancer progressed, there was a significant increase in the perception of pain. However, when these animals were treated with antibiotics, we found that this pain perception was attenuated, and that the antibiotic animals had a lower von Frey threshold for mechanical pain. But the differences in the perception was different between week 2 and week 3, where tail flick and von Frey were significantly greater at week 3, but the tail flick measurements were not significant at week 2. So to understand what is driving pain in this different model system, we looked at the microbiome of all these different treatment groups, control, morphine, antibiotic treatment, cancer, and cancer plus antibiotics. And to make a long story short, we came across 2 taxa that was constantly altered in the animals that were perceiving pain, and that was Enterococcus and Lactobacillus. And there was a reciprocal relationship between the two. As Enterococcus increased, the perception of pain was increased, or the pain threshold was perceived to be greater, whereas Lactobacillus decrease resulted with lower pain threshold. And so once again, Lactobacillus is associated with lipid absorption, maintenance of internal barrier function, and protects against inflammation, and also inhibits NLRP3 inflammasome. On the contrary, Enterococcus disrupts barrier function, induces pro-inflammation, and induces NLRP inflammasome activation. So here we see that there's a strong correlation between the ratio of E. faecalis to Lactobacillus, and therefore the pain score is negatively correlated with increase in Lactobacillus, implicating the Lactobacillus could be a good probiotic to be used to maintain or retain the efficacy of opioids as an analgesic agent. So in summary, microbiome plays a crucial role in cancer. Microbiome reduces efficacy of opiates as an analgesic agent, and manipulating the gut microbiome as an adjunct therapy with opioid use can prolong analgesic efficacy of opioids. With that, I'd like to acknowledge most of the work here was done by Rajiv and Irina, who did most of the pain studies. Li Zhang did the opiate tolerance studies, and the pancreatic cancer model was developed for us by Dr. Ramakrishnan's group with the help of Dr. Bhuvangiri and Janet Olias. And of course, this is not possible without funding from the various sources. Thank you.
Thank you, Dr. Roy, for the wonderful talk. So how do you take this from the laboratory to the clinical? Have you started looking at some clinical trials to use some of these strategies to address pain in pancreatic patients?
Right. Probiotics have not been very successful, as you know, and we have tried it mostly in HIV patients, and it's not been very successful modulating pain. However, now we are trying a therapy where it is not that probiotics don't engraft, so you have to readily repeat the treatment. So we are trying to use a symbiotic approach where we are treating animals with the lactobacillus, but giving it the substrate that it requires to sustain itself. Because most of the time, these bacteria are depleted because of a lack of the substrate. So we are genetically engineering commensal bacteria so that it produces the appropriate substrate that is required for the sustenance of the anti-inflammatory bacteria.
Thank you. Any questions?
Any other questions? Okay, thank you very much.
Thank you.
So it's my pleasure to introduce our last speaker of this session, and that's Talia Golan. Talia is the head of Sheba Pancreatic Cancer Center and at Sheba Medical Center. She's the director of phase 1 clinical trials, and she's recently published a good bit of work on a new therapeutic regimen called POLO for patients with BRCA1, BRCA2 mutation. I was looking at her CV and some of the literature, and I could go on and on, but I think what sums up the impact of her work the best is that Forbes magazine named her one of the 50 most influential women in Israel. So congratulations on that, and I look forward to your talk.
Okay, so thank you for the invitation, and it's delightful to be on the stage once again. My first face-to-face meeting. So I've tried to take the BRCA mutations into the setting of surgery. These are my disclosures. And it's speaking just a little bit about using precision medicine in the neoadjuvant approach. So when you think about personalizing treatment in pancreatic cancer, we have the prognostic predictive biomarkers, biopsies for integrated characterization, and blood for taking germline mutations. And then you have your clinical decision-making, specifically the difficulties of an anatomy definition of resectability, and then maybe additional biological and patient conditional varieties that are going to come into consideration, and then patients' preferences. And all this is going to come together when we think about how to personalize our treatment. Specifically, if we think about the prognostic and the predictive biomarkers, for the relevance of this talk, I'm going to focus on the BRCA1 and 2 mutations. So what is actually the prognostic value of a germline BRCA mutation? I personally still don't know how to answer this question, but I think that it's less of a prognostic biomarker. For example, in a study that we looked at patients with advanced disease, we saw that median overall survival was 14 months versus 4.4 months in a non-selected patient population. So it seems to have a better survival. But in a more recent study, in patients with pancreatic cancer and germline BRCA mutations, overall survival was worse in patients with germline BRCA mutations. However, when we think about the predictive biomarker, we can say today with much certainty that patients who are exposed to platinum-based treatment especially in the early setting, but also in the advanced setting, have a superior overall survival. We have showed in a very old study that patients who were exposed to platinum during the course of disease had a much, much higher overall survival than those that had not been exposed to platinum. Why did we not give platinum to those patients? Because then there wasn't the heightened awareness to give platinum to patients with BRCA. Mike Pishvian has also showed in a much larger study with over 400 patients, in patients with DNA damage repair alterations in their tumors, including BRCA, but not only specific for BRCA, that when exposed to platinum, once again, an extended overall survival. So we say that we have a predictive biomarker, and let's think how we can use it. So this is a study done in 2 centers in Israel with a colleague of mine, Dr. Lubetsky. We looked at patients with borderline pancreatic cancer that received neoadjuvant treatment in the setting, and we determined their BRCA mutation status. Between us, we found 44 patients, and 9 of them had germline BRCA mutations. In the patients with a germline BRCA mutation, pathological complete response rate was 44% versus 9% in the patients that were non-carriers. One can see the median disease-free survival of 45 months in the BRCA versus 23 months in the non-BRCA. Median overall survival has still not been reached in the BRCA cohort and is 33 months in the non-BRCA cohort. So here we see a nice model of how BRCA germline mutations is really a predictive biomarker for using platinum-based neoadjuvant treatment. And I'd like to share a case study with you. So this is case number 1, a 45-year-old male who came in with abdominal pain. His CT images showed a mass in the pancreatic, head about in the SMV. There was also an undetermined lesion in his pancreas, in his liver, and some small lung lesions. His CA99 levels were not elevated, and a biopsy confirmed adenocarcinoma. We initiated neoadjuvant FOLFIRINOX. There's a question mark next to the FOLFIRINOX because we weren't quite sure it was neoadjuvant. There were a few lesions that we were uncertain of what they were. He had no family history, but he was Ashkenazi Jewish, and he was a germline BRCA mutation. Here you can see the CT scan at diagnosis. You can see a nice big tumor in the head of the pancreas, and it's abutting the SMV. And when we did a PET scan, we saw there was uptake only in the tumor and not in the liver lesion. So we thought he was probably not metastatic. And then you can see here, the CT scan on the 4th in 2015, once again, the lesion abutting. And then after only 5 treatments of neoadjuvant FOLFIRINOX, you can see that there's almost nothing left of the tumor. There's this remnant there that you can see illustrated. So literally the tumor just disappeared under our eyes. And we looked at the MRI and RCP just before he went for operation. Once again, there may be a remnant of what was the pancreatic tumor. The patient went for a Whipple procedure, and you can see his pathological report had a maybe single atypical gland with a minimal residual carcinoma, and there was a very strong therapy effect, and 30 lymph nodes were free of malignancy. He continued to receive another 4 cycles of adjuvant FOLFIRINOX at a reduced dose and remains disease-free till today. However, unfortunately, not all the patients behave similarly. This is a case study 2 that I'd like to share with you, a patient that came in this year, 67-year-old, with, once again, a lesion abutting the SMV and this time also the SMA. His CA99 levels were elevated. Biopsy confirmed adenocarcinoma. We once again initiated neoadjuvant FOLFIRINOX, and he was a BRCA2 mutation carrier. He had no response to treatment. He very quickly developed ascites, and he actually died within 7 months of his overall survival. So his overall survival was 7 months from diagnosis. So this patient illustrates a sample of primary therapeutic resistance. And this really leads me to the thought that really not all germline BRCA patients are born equal. And we've seen this in the metastatic setting, and we see this again also in the even earlier disease, when we sometimes think that the tumor would maybe have less mechanisms of resistance, and we may have more, see this primary resistance less. In the slide, I'd like to share with you some unpublished data. This is about 90 patients of ours. You can see in the swimmer's plot the spectrum of response to platinum and or PARP treatment. And it's interesting to see that there's 3 distinct subgroups of patients. There's a group of patients that have an innate resistance. So even though they're germline BRCA mutation, they receive platinum treatment, they have innate resistance, they die within several months of diagnosis. Then you have the super responders, the patient that go on to receive platinum and then PARP inhibitors, and they go into long-term remission. This is more than 3, 4, 5 years. They're a small subgroup, but they're distinct, and we're seeing them more and more now as we identify these patients. But the bulk of our patients are these middle patients with the acquired resistance. So they respond for about 2 years, and then at around the 2-3 year mark, they have acquired resistance. What we've tried to do in the lab is to recapitulate this specific clinical phenomena that we've seen, and we take tumor from biopsies, ascites, resection when possible from FNBs, which is much harder to make a model. We propagate the cells in a PDX model, and then we develop organoids, and then sometimes we also use orthotopic models. But now we have model systems that really capture these 3 distinct clinical scenarios that we've just discussed, the innate resistance, the acquired resistance, and the super responders, and we're trying to investigate these patients more deeply. So to finalize, and this is my last slide, and I'm on time, there's really many, many barriers to implementation of precision medicine for pancreatic cancer, and I don't need to tell this audience, you know it. I'd just like to maybe illustrate some specific things. I think one of the most difficult things is tissue acquisition. This is specifically for patients in the neoadjuvant setting, and it's really, really difficult. We try to get as much tissue as we can, but even from the FNBs, it's really hard to make model systems, or sometimes even to just do deep sequencing. So that's a real barrier, and also, even if we get a sample, then we've had this low cellularity that we know is very predictable about our pancreatic cancers. Then we have the technology-specific things. So there's still inconsistency with which omics should be done and in which way, and there's also data interpretation that's not, it's not maybe equal between the different institutions, and commercial tests are also being done. And then we have the timing of molecular testing, also to do extra biopsies for patients that need to go into treatment, and then turnaround times. And then probably maybe the most problematic thing is the therapeutic development. So we really have a lack of biomarker-based clinical trials. When I did my last check, it was about 3 to 4 biological-driven trials in the neoadjuvant setting. So even if we identify patients, to try and to put them into specific clinical trials is very, very challenging. And often in these scenarios, we have to really try and make, a system open for the patient, if, going to a company and trying to get compassionate use of certain drugs, which is really not a very good way to do academic medicine going forward and learning from it. And then and this is really, it's been something that I've seen over the years, and I do see it less in the neoadjuvant setting in the BRCA patients, is this primary therapeutic resistance. We see it more in the advanced setting, but we do see it also in the early setting. And that's something that even I think about, what study would I do for these patients? I don't know. I don't know. I know that they often respond really nicely to radiotherapy, like where maybe we should be giving them GemCis and radiotherapy when we can identify the primary resistant patients, but that may not help already the systemic spread that's probably going on already. So there's lots of unanswered questions, but I think together as a scientific community, this is really a very, very special and unique place where we can try and understand pancreatic cancer, where we do see less primary therapeutic resistance. So thank you.
Thank you for that excellent talk.
And on time.
Yes, excellent, very good job. In your plot of stratifying patients based, so they're all BRCA, but then there's this variation in sensitivity to platinum. Is there, in that cohort, has there been a deeper dive on those? Like, are there unique mutations of BRCA that tend to be resistant? And I take it those are germline BRCA?
Yeah,
I mean, how we, because they have a germline doesn't necessarily mean that they have biallelic inactivation in the tumor, and are these, BRCA-driven tumors that respond versus not? Are those sort of things known?
So if you think, if the swimmer's plot, I can go back to it. It will just be maybe easier to speak. Oh, there's no time. So
it's okay. There was that 4 breakpoints.
There's the three. So the majority of our patients are going to actually respond to platinum-based chemo. It's a small minority that have that innate resistance. And we looked at mechanisms of resistance. The majority of them is is that they don't have loss of heterozygosity in the second allele. So that's the main one. So even though it was probably important in the development of the cancer initially, when we're seeing the cancer, it's not playing a driving mutation anymore.
No longer a driver mutation.
But that's in about 20% of the cases. In 80% of the patients, we still have loss of heterozygosity, but we can still have resistance, strong resistance mechanisms. And we are seeing a difference also between ovarian cancer and breast cancer. So, for example, we see more BRCA2 in breast and ovarian, they see more BRCA1. And we have seen, and this is actually, we haven't published this yet, but we've seen in the BRCA1, they seem to be more enriched in the innate resistant population. So there is obviously something that has to do with the KRAS as well that we don't understand yet.
Do they further stratify? I'm sorry, Dan, but 1 sec. Just if you take those responders and if on the expression profile, basal versus classical, and then further stratify for the ones that are biallelic but don't respond, then do they fall maybe in the basal category, or is that's not known?
So it's not known, but they seem to be more basal-like in the BRCA1 as well. So that goes back to a more aggressive subtype as well. And also they have more P53 mutations, the BRCA1 as well.
Sounds good.
Yeah, but these are all like small numbers. If you look at cohorts, we're talking about like very small numbers.
Sorry about that, Diane.
No,
Dr. Simeon?
No, those are some of the questions I had, because it's interesting because we still see clinical trials in the BRCA space where there's not an HRD score done or verification of LOH, which is kind of still surprising.
Yeah.
And
we
you
published together with Gallinger's group in gastro an HRD score that.
Yeah, so I thought that was actually very compelling work that an HRD score should be included in all reports, and I don't know that it is. And you alluded to it, but there was a paper, I forget it was in ovarian or breast, where they showed actually distinct immune signatures in BRCA1 versus BRCA2. And I was curious if it's kind of along the lines as we lump BRCA together, and maybe, and even PALB2, but maybe you can comment on the differences you've observed.
Yeah, so we've seen, I don't want to go too deeply into it, but there was a lot of misunderstanding in our field, which is, there's more clarity now. When we spoke about DNA damage repair alterations, we kind of linked them to HRD, but a lot of the DDR are not HRD. For example, ATM does not have an HRD signature. We know that today, CHEK2. So those that have a much smaller group, it's RAD51, PALB2, BRCA1, BRCA2, BRCA1, 2, also somatic and also germline. They have a higher tumor mutation burden, all these tumors, slightly higher. So there is, and if you look at the RNA-seq, they have higher infiltrate as well of RNA-seq related pathways as well. And I think that and also when you look at those, the only thing, or what I can say, when you think about those long-term survivors that are going into remission, like 5, we also have 10-year survivors on PARP inhibitors. There's some engagement there with the immune system that we haven't been able yet to explain, but that we are hypothesize it is happening. So there is probably an opening in the field going for immunotherapy, but how? It's not going to be easy. And checkpoint inhibitors alone are not working, that we all know from the field.
Excellent. Well,
Thanks.
thank you very much, and this ends that session. Thanks.